Good afternoon, everyone. My name is Christopher Pearcy, and I'm here to present our project, Risky Business. We have a long list of authors here. Lots of people contributed. We conducted this over a few different sites, and so we want to thank everybody for their contribution to the study. The primary site was at Methodist Dallas Medical Center in Dallas, and it was under the supervision of Dr. Michael Truitt. No financial disclosures to present. And our objectives. So we wanted to look at patients coming into the hospital on pre-hospital antiplatelet drugs and determine if that affected outcomes in urgent laparoscopic appendectomy. And a little bit of background is appendicitis is the third most common indication for abdominal surgery in the elderly. Mortality is reported at least 8 times higher in elderly patients, and this is often attributed to multiple comorbidities and the associated polypharmacy. And then in addition, given that laparoscopic appendectomy is a pretty benign procedure, lots of these patients proceed to the OR with maybe an incomplete or minimal preoperative health assessment. So our clinical case is a 70-year-old male with right lower quadrant abdominal pain and CT findings consistent with acute appendicitis. He has past medical history of coronary artery disease, hypertension, hyperlipidemia, diabetes, and has had a stroke in the past. So he has a long medication list, but of note, he is taking Plavix and aspirin daily, and he's scheduled for an urgent laparoscopic appendectomy. And so our question is it safe to proceed with this procedure given the antithrombotic, antiplatelet therapy? So we should do a risk-benefit analysis in our heads and determine it's okay to proceed with surgery and accept the risk of bleeding, the potential risk of bleeding, or do we want to delay surgery, maybe treat with antibiotics and stop the medication, which could potentially risk thrombotic complications, and then how does all of this together affect rates of infection or perforation? So we conducted this, as I said, it was multi-center. These are the 3 centers' data included in the study here. And again, thank you everyone for your input. The study period was from 2010 to 2014. Our inclusion criteria were any non-pregnant patients over the age of 18 years undergoing urgent laparoscopic appendectomy on antiplatelet drugs, as I said, from 2010 to 2014. And we excluded anybody who had an appendectomy for a reason other than appendicitis, so hysterectomies or Whipples. We also excluded open appendectomies from the study. So after we got data from all of the centers, we had 1,510 total patients, complete data for those patients. We identified 195 patients taking antithrombotics at the time of surgery. And those were matched 1-to-1 for age and gender to 195 control patients. And just so you know, about 96% of these patients were taking aspirin or Plavix, and the remainder, the small remainder, were on NOACs, Pradaxas, or Elto and Eliquis. Our primary outcomes were blood loss, transfusion requirement in the intraoperative and postoperative periods, and overall mortality, and then length of operation, hospital length of stay, infections, complications, 30-day readmissions were secondary outcomes. These are our results here, and as you can see of note down the right-hand column, nothing was significant. So 18 versus 22 cc's of blood loss, nothing different in the transfusion requirements in the pre-intra or postoperative period. Length of operations were comparable, length of stay was the same. We looked at surgical site infections, organ space infections, and deep space infections, all of which were the same. No significant difference in overall complications, 30-day readmissions, or mortality. We did have 2 mortalities in the antithrombotic group, but that was not significant overall. So just to summarize, compared to controls, we didn't find any significant difference in any outcome whatsoever in the patients taking pre-hospital antithrombotics after laparoscopic appendectomy. And so going back to our case at the beginning of the presentation, is it safe to proceed with surgery given the IAT therapy in this patient? And based on our data, we would say yes. Here are references, and happy to take any questions.
While somebody's walking to the mic, given that you essentially showed that you did not reject your null hypothesis, what did you power against to get your number? Like which of those many outcomes that were not equivalent was your primary for your power analysis?
Can you say it again?
Like when you were designing your study to look at this question, which of those primary outcomes did you use to decide how many in each group you needed to make these conclusions?
We looked at the estimated blood loss and transfusion requirement. And I believe we wanted around 100 in each group originally, and we were able to surpass that.
Study was conceived, he helped execute it, but he was not involved in that phase. So it was 150 patients was the power analysis, and it was primarily around EBL and transfusion requirements.
So all these, he has a question there, just real quick. So all of them are the same? You know, Produx is not worse than Plavix, not worse than anything else. So you're saying we can operate through all these drugs at any time for an appendectomy and be safe? Is that what you're trying to say?
I would say for Plavix and aspirin, we have sufficient data to say that's okay. We would have liked to have more data on the NOACs, the novel oral anticoagulants. Unfortunately, that only made up 4% of our total cohort, so I don't think we can definitively say that.
That was actually my question, was to ask about whether you're going to, increase the breadth of the study or to try to include those 3 other drugs. But I guess, at some point you'll have enough patients the way things are going right now. So.
Yep, we're collecting data from 4 other centers as well to try and get those numbers up. And hopefully we can get more of the NOACs in there to make a better conclusion about them.
Jason Paisley, University of Maryland. Did you look at any non-operative therapy, especially for these high-risk patients with recent stroke, recent revascularization, less than 3 months or something? Did you look at any non-operative therapy and maybe compare that to this group?
We did not in this study. That's a great question, and that's something we can consider going forward for sure.
Sarat Sujatha-Bhaskar, UC Irvine. You said about 95% of your experimental trial was on aspirin Plavix. Did you guys do any PFAs to validate that they were truly inhibited for platelet function at all? Just sometimes people say they're on aspirin Plavix, but they're non-compliant, they're not taking it, so.
Yeah, we didn't, just because of the retrospective nature of the study, that data wasn't available, but that would be very helpful. I agree with that. Thank you for the question.
Great. All right. Thank you very much.
Thank you.